if you want to do something different, then so you want to share. Okay, let me go ahead with a short introduction, and then you can get started. A second here. Now what happened to my introduction? There we go. Okay. Oh goodness, technology, right? Okay, here we go. I'm Cynthia Snedden from the Education Office in Oakrest, and it's my pleasure to be here to introduce our speaker today. Today we are here to learn about multi-cancer early detection assays. Many of us may have heard about this important topic recently, but today we will hear the latest news and learn about the possibility of just such a study coming to our institution. Our speaker is an experienced breast oncologist with more than 30 years of expertise, who currently serves as the Director of Breast Medical Oncology and the Director of the Cancer Clinical Trials Office here at the University of Colorado. Excuse me. She also serves as the co-chair of the Prevention Committee for the Alliance for Clinical Trials in Oncology, in addition to serving as the Deputy Director for Cancer Prevention and Control within Alliance. She completed her medical studies and her fellowship in Colorado before moving to the East Coast to practice medicine at the University of Vermont. Now, 20 years later, she has returned to the University of Colorado to continue practicing with research focus in cancer prevention. She sees patients in clinic at Anschutz Medical Campus and Highlands Ranch Hospital. It's my very great privilege and honor to introduce Dr. Marie Wood.
Well, thank you for that great and very kind introduction. I thought it might be fun to talk a little bit about multi-cancer early detection assays. I don't know what you guys have heard about them. A lot of people have been talking about them. There's a lot of press out there. And I'm going to talk a little bit about really, are they ready for prime time? So as I think everybody here knows, but if not, let's just back up and think a little bit. I'm going to try and move some things out of the way. Okay. As most of you know, there are guidelines for several types of cancer: breast cancer, cervical, prostate, lung, and colorectal cancer. The screening tools used and recommended for each of these cancers are different, obviously. The age at which we start screening ranges from 21 for cervical cancer to 50 plus for prostate cancer, and the frequency with which we do testing also varies. There are a lot of issues with cancer screening. As I mentioned, testing starts at a variety of ages. It's done at a variety of intervals with a variety of techniques, each of which have different invasiveness. Testing is associated for many of these screenings, cancer screening protocols, with high false positive rates, which means a lot of callbacks for patients, a lot of anxiety, and low positive predictive value, meaning that the threshold for calling people back is set so that we do get a fair bit of false positives. There are issues of overdiagnosis, especially with breast cancer, and overtreatment. And this is a common thing that we talk about. There's also disparities in adherence that are an issue, especially for people who are underinsured or uninsured, not having great access to primary care, and therefore not having access to these screenings. The current cancer screening will identify less than 50% of all cancers if you look in aggregate about what are the most common cancers. And 71% of cancer deaths occur in types of cancer with no recommended screening. Back in I don't think this is November of 2022, but November of 2021, there were some stories that hit the social media about a new blood test that could spot more than 50 types of cancer, many of which were hard to detect. CBS Minnesota reported this as a game changer. And when you look a little bit closer, you see that the results for this test are sent back to healthcare providers in 10 days. And then a study that was really performed largely at Mayo Clinic, and I'll show you more about this, looked at 6,600 participants and returned 29 signals that were followed by a cancer diagnosis. So that's a really small percentage of people that are tested positive. Currently, the test is prescription only. Insurance doesn't cover the test, and you pay out of pocket with a current cost of almost $1,000. So what I'm going to talk about with that introduction is a little bit about how these tests work, what cancers they detect, and think a little bit about who should order these tests and how they should be incorporated into standard screening. And I'll end with talking about a study that I hope to be able to open here that will be activated in August. This is an NCI study to gather a reference set for these multi-cancer early detection assays. So multi-cancer early detection assays are based on the principle that both normal and cancer cells shed DNA, RNA, proteins into circulation, so we can actually draw blood and test for this DNA, RNA, or proteins. Currently, there are 3 technologies, or the most common technologies, that look at these tests include whole genome sequencing for a methylation pattern, whole genome sequencing for genome-wide DNA fragmentation patterns, not methylation pattern, but DNA fragmentation patterns. And then the third test is a combination of PCR to detect driver mutations, and then looking at validated protein biomarkers. These 3 technologies are used by a number of companies who are working on these assays, and you may have heard about many of them. But right now there are 5 companies that are promoting these multi-cancer early detection assays. Some of them, like Delphi, are doing it primarily for lung cancer. Others, like Grail and Thrive, are doing it as a true multi-cancer early detection assay. The one that we heard about earlier is the Galleri test promoted by Grail. And I'm going to talk, I decided to only for time talk about 2, and those are really the ones that we hear the most about, which is the Grail test and the Thrive Cancer-Seq test. The Thrive Cancer-Seq test is based on a test that looks at both biomarkers and circulating DNA. This test is done by getting a blood sample, looking at DNA fragments or amplicons, and then a 8 protein-based panel. So they use a combination of PCR to detect these mutations, and then testing a validated biomarker. They're looking for 16 mutations in 16 different genes and 8 different biomarkers, many of which you may associate with blood tests that we use to look for cancer recurrence. Those who test positive go on to have a confirmatory test that looks at more amplicons and more proteins, and then uses a machine learning algorithm to integrate data with the additional serum proteins, patient gender, to predict actually tissue of origin. Their study on 1,000 cases and 800 plus healthy controls identified a sensitivity of between 33 and 88%, with an overall sensitivity or area under the curve of 91%, which is a highly accurate test. When you then look at the ability of this particular test to predict tissue of origin, the accuracy ranges from very high for ovarian cancer and primary liver cancer and very low for breast cancer. In a prospective study done looking at this particular test, they enrolled 10,000 women between the ages of 65 and 75 at 18 sites associated with the Geisinger Health System. These individuals were enrolled between 2017 and 2019. Those who enrolled had a baseline test. If they scored positive, they went on to have that confirmatory test after excluding certain red herrings, such as clonal hematopoiesis of indeterminate significance or CHIP. And then if that test was positive, they went on to have imaging. Majority of imaging looked at a PET CT, but they could do additional imaging if warranted. And then they returned these results to the patient with continued follow-up. Participants whose PET CT showed features of concern were referred then to a specialist for further evaluation. And all participants were asked to complete detailed surveys and then follow up at 12 months. They embedded a lot of safety features, as you might think, into a study. And I think it's important because this really talks to you about what are some of the limitations and what do we need to watch out for with this testing. At baseline, participants were counseled about the implications of both a positive and a negative test. A positive not necessarily being truly cancer, and a negative test not necessarily ruling out cancer, so that they should really continue with standard of care screening. Regarding the confirmatory tests, in this particular study, they did the confirmatory test on an equal number of participants who were negative and positive, just to minimize anxiety. Results were relayed to participants in a careful and scripted manner. Imaging was done with PET CT and reviewed centrally by 2 expert radiologists. When they returned results of positive CTs, it was done after reviewing this information using a multidisciplinary review committee. And then it was recommended for all individuals, regardless of their results, to continue standard of care screening. This study enrolled, as I mentioned, almost 10,000 patients. They had 490 with that positive baseline test. Of that group, 134 had a positive confirmatory test, so less than 20%. Of that population, 64 went on to have a PET CT with a concerning finding. And of that population, they found 26 cancers. Only half of them were early stage cancers. So when you look at the stats, this is a positive predictive value of 40%. A sensitivity fairly low at 27%, but when they did find a cancer, they were able to identify the tissue of origin with high specificity. Interestingly, in this study, over the following 12 months, there were another 24 cancers detected by standard of care screening, and 46 cancers were identified by test initiated due to symptoms. So is this the answer to our questions? I'm not sure. They're actually doing a follow-on test, which is a validated observational cohort. Accrual is completed for this study. The next test I want to talk about is the Grail-Galleri test. This is the one we've heard about in the news. It uses whole genome sequencing for detection of a methylation pattern. This, as I mentioned, is used by several companies, use this technique, and it uses evaluation for methylation pattern, actually circumvents several issues. One is the limited number of recurrent mutations available to distinguish tumor from normal. And so if you're just using DNA and looking for mutations, there's only a few that clearly tell you tumor versus normal. The cost for this kind of testing is lower, and technical artifacts can be introduced during sequencing, and this looking for methylation pattern circumvents that issue. The GALE test, the GRAIL-Galleri test was studied in a large 15,000 participant study that included untreated cases. So patients who were diagnosed with cancer had samples taken prior to undergoing treatment. In this study, there were represented 50 tumor types, and they also had another cohort of healthy controls. Patients were enrolled between 2016 and 2019 from sites all across the US. This particular study, once they accrued their patient population, they divided it into 3 different studies. The first sub-study was a discovery analysis of 3 independent assays. The second study was further analysis looking at validation, and the third was further validation. I'm going to go through each of these studies for you. The first sub-study was really a discovery portion. They looked at several genomic sequencing approaches and identified the whole genome, what's called bisulfite sequencing detecting method, as outperforming other methods. The second sub-study was training and validation, focused on refinement of the assay that they identified. They actually had very high specificity. Up here in the upper right, you see that the training set had 99.8% specificity. So that means if they detect a cancer signal, it's accurate over 99% of the time. And the validation set was similarly specific. They looked at over here, the sensitivity in a pre-specified set of cancers that encompassed about 65% of cancer deaths. You see those cancers listed here. And when they compared the sensitivity of their pre-specified group compared to all types by stage, let's look at all types first. You see that they're very accurate in both the training and validation set of identifying and finding metastatic cancer. That's not really what we need in a screening or in an early detection assay. The accuracy or sensitivity dropped if you looked at the stage of cancer identified. When they then compared that to a pre-specified group of cancers, those that seem to be the most deadly, they had a similarly high rate of cancer detection for stage 3 and stage 4. It dropped off for stage 2 and stage 1, but it did seem to perform better in this pre-specified group compared to all cancer types. When they looked then at the sensitivity for stage 1 through 3 for all cancers, it was less than 50% at 43.9%. But when they looked at their pre-specified set, it was much higher at 67.3. They were very accurate at predicting the tissue of origin, whether it was stage 3 or stage 4, whether it was all cancer types or just that pre-specified set. So I think that the take-home message is that this particular test is pretty accurate at predicting cancers, not as accurate when it comes to stage 1, which is really where you want to find a cancer early. In the third part of this sub-study, the clinical validation part of it, they used 5,300 participants from the total study and looked at evaluation of test performance for cancer signal detection. The overall sensitivity was 51.5%. and the sensitivity did increase with stage. The overall specificity was high again at 99.5%, with a false positive rate of 0.5%. Remember, there's a group of people with cancer and a group of people without cancer. And down here, when they looked at sensitivity by cancer type, you see the same thing as in the previous test. Low sensitivity for breast cancer, much higher for ovarian and liver cancer, primary liver cancer. This test was then used in a prospective trial to look at multi-cancer early detection testing using this test in a real world detection setting, not just collecting cases and controls. The objective of this test was to assay the extent of diagnostic tests required to achieve diagnostic resolution. So they keep doing tests until they feel they've come to an endpoint, which could be a cancer or looked for a cancer and couldn't find it. They also evaluated test performance and participant outcomes and perceptions. This study included 6,200 participants at 15 institutions. Individuals were eligible if they were over 50. They had two cohorts. Cohort A had one or more risk factor. That risk factor could be smoking, a prior history of invasive cancer or hematologic malignancy, or a germline mutation. So these people are at pretty high risk. They then had a cohort B who had no additional risk factors. So in this study, if they didn't detect a signal, the patient got that test report back. They recommended and reinforced standard of care screening and then reassessed cancer status at 12 months. If they did find a signal, they then worked with the provider, determined the diagnostic evaluation, and they kept doing tests until they came up with cancer or were satisfied that none could be detected. Cancer status was assessed at 12 months. The test reports were given back within 15 days of a blood draw. They completed accrual for this study in December of 2020, and they presented their data at ASCO 2021. So not this year, but the previous year. This, and I hope you can all see this, looks at the suggested workup based on the tissue of origin, which was suggested from the testing. So for multiple myeloma, they recommended, as you might think, a blood workup with a CBC, a smear review, chemistry tests, protein and your protein electrophoresis of both blood and urine. For esophageal or gastric source endoscopy, colorectal colonoscopy, exam for head and neck, pancreatic, all of these tests are things that you might expect to do if we thought we had a cancer diagnosis. The interim results were presented at ASCO 2021. They analyzed 6,600 patients. Their average signal detection by risk for the entire cohort was 1.4%, lower for the average risk group, a little bit higher for that high risk group. Remember, that's a pretty high risk group of both patients with cancer who are at risk for additional cancers or recurrence. This represented 60% of all positive signals. When they looked at the positive predictive value by risk, on average, it was 44%, lower for an average risk group and much higher for a high risk group. Kind of begs the question of maybe we should be using this test not in an average risk group where the likelihood of finding cancer is going to be pretty low, but maybe you want to really look at a high risk group where the yield is going to be much higher. Looking a little bit closer at this, they had 66 plus 100 patients. There were 6,500 with no signal detected. Of those, 92 or 1.4 who had a signal detected, this resulted in 65 who had scans to diagnostic, or who had an evaluation taken to diagnostic resolution, of which 25 were a true positive, and unfortunately 36 with a false positive. So in my opinion, that's a pretty high false positive rate. Less than half of the people who they did a diagnostic evaluation and felt they got resolution were taken to this through this evaluation and didn't detect cancer. Looking at the results, most participants with diagnostic resolution had at least one imaging test. There were more true positives than false positive, and at least one had an invasive procedure to get to a true positive result. Days to resolution on average for this diagnostic workup is 50. So that's in a month and a half to get a positive signal, to then be working that signal up to find out that you either do have cancer or don't have cancer. It was a little bit longer for diagnostic resolution for a true positive than a false positive. So I think we have to really be careful. While these tests might be exciting because they find a lot of cancer for which we don't have screening tests, there still is a cost to these assays, and that's not just the cost of doing the test. Looking at these results a little bit closer, for the 23 cancers that were identified, 60% were stage 1 through 3, and less than 40% were stage 1 and 2. 5 of the patients with cancer were actually recurrent cancers, 4 of the breast, 1 of the prostate. Follow-up is ongoing for this study to determine sensitivity and specificity and determine screen and symptom detected cancers. So, as I mentioned, there are 3 techniques and several companies that are using these techniques and are promoting these multi-cancer early detection assays. I think the success of these early detection assays depends on determining the sensitive and specific detection of clinically relevant malignancies at the earliest possible stage. It's also really important that we detect early stage cancer across all major tumor types and identify those cancers that will impact survival, while avoiding detection of pre-malignant and benign lesions, and determine tissue of origin. A lot to do with these assays, in my opinion. When we think of considerations for screening with a test like this, we need to think about the sensitivity of detection in intended use populations. As I mentioned, do we just look at average populations, or do we just use these for high-risk populations? What's the frequency of testing? All of the studies I showed you, which isn't a huge number, looked at one test and then following that up. What about the reconciliation of false positive and false negative? What is going to be the recommended screening tests for a positive test? And what are the appropriate clinical workflows for a positive test? Additional important considerations should include who should get this test. As I mentioned, do we just identify high-risk populations? Do we use it for symptomatic patients or patients with indeterminate physical or radiologic findings? And we haven't really talked about this, but who should order the tests? A primary care provider who may or may not really know the diagnostic evaluation or really think as much about cancer as a subspecialty provider. And how do you work up a positive signals? Companies report positive or negative, and they don't script the workup. And these will be generally asymptomatic patients. And if initial screen is negative, how should individuals be followed or monitored? And who works up a positive test? Does the primary care provider order the test? And then if they're positive, ship the patient off to a specialist? Remains to be seen how this should be done. Some positive signals do suggest one tissue type, but the workup reveals another, so we really need to keep a broad focus here. So what are the next steps for these multi-cancer early detection assays? There are industry-sponsored studies are underway to determine the accuracy of these tests, to clinically validate these tests, and evaluate implementation of pathways for assays of multi-cancer early detection. Despite the lack of evidence to support the clinical utility, at least one assay is now commercially available. And several companies have contacted the NCI and the Division of Cancer Prevention for interest in studying these multi-cancer early detection assays. The NCI is very interested in performing a definitive trial for clinical utility in a screening population. However, before they perform a definitive study, they have asked Alliance for Clinical Trials to gather a blinded reference set for early cancer multi-detection blood tests. And I happen to be, and am fortunate to be, the chair of this protocol, which will be activated in August, and I hope we can open it here. This test will be a blinded reference set. The primary objective of this study will be to provide a reference set of 1,000 cancers and 1,000 non-cancer patients to be used to verify the performance of multi-cancer early detection assays that will then be utilized in a prospective trial focusing on defining the utility of these MCED assays. We have a couple of secondary objectives. One is to evaluate test performance at the time of a cancer diagnosis by tumor type, and also to evaluate test performance at the time of cancer diagnosis by clinical stage. We are going to study 3 populations. 1, patients with newly diagnosed cancer. 2, patients with high suspicion of cancer. And 3, patients without cancer or healthy controls. Here's the study schema. It's pretty simple. Patients are deemed eligible, and they have either have cancer but haven't been treated, have a high suspicion of cancer and need to go to surgery, or they don't have cancer. We will collect blood and data on these patients and specimens. If they say yes, they then will be registered, and then we will collect their data down the road as well. Cancer patients should have labs drawn prior to any treatment. There is what's called a slot reservation, which will be a little bit complicated for the enrollment because we're really trying to collect cohorts, so several stages, several tumor types. There's an optional second collection at 12 months. To be eligible, patients must be age 40 to 75. We chose this age group thinking about standard of care screening, and they cannot have had a previous organ transplant or exposure to immunosuppressive medications, as this commonly interferes with the assay. Cases are either newly diagnosed, they might be suspected cancer that then has to go to a definitive surgery, like pancreatic cancer or ovarian cancer. Again, they have to be untreated, and they can be anywhere from stage 1 to 4, not stage 0. Controls must have no specific cancer risk. So we're looking for people actually who might be at institutions enrolling these patients, or they could be companions coming in with the patients. And we will match them by age and sex to the cases that we collect. This is a list of all of the eligible tumor types. So we're trying to collect all stages within each of these tumor types for 1,000 cases. For patients with high suspicion of cancer, such as I mentioned, ovarian, pancreatic, or kidney or melanoma, where you put them through a definitive surgery to make the cancer diagnosis, they have to have a planned surgical resection within 28 days of study enrollment. We then get documentation of their suspicious findings, and we'll review that centrally to confirm that the patient really should be eligible. The study schedule is pretty simple. At baseline, we get 60 mLs of blood. They can give a tissue block, but that's optional. They provide some demographic data such as age, sex, ethnicity, smoking and family history, and cancer stage. At 12 months, we get their cancer status, especially important for the healthy controls, and blood, but that's optional. Here is the calendar. And so after consent and within 28 days prior to registration, we get demographic and health information. They complete a patient questionnaire. Within 28 days after registration, we want to get BMI, clinical staging, and documentation of final cancer diagnosis for those who are undergoing surgery. We also get tissue and blood samples. At 12 months, we'll then reach out to them to confirm their cancer status and get optional tissue and blood samples if available. For healthy controls, we're getting the same demographic and health information. They complete a similar questionnaire. We get body mass index, blood samples, and we reach out to them at 12 months to determine their cancer status. Special issues for this study is that it requires accrual of participants prior to any treatment. So these may be patients who are presenting to multi-cancer, to MDC clinics, and that may be a really good way to accrue these patients. Accrual of participants with suspected cancer will be a little bit difficult and different, so they have to be accrued prior to going to surgery. We've been thinking a lot about how do we accrue healthy controls. So participants will be asked for names and contact information of people who are the same sex and age and might be willing to consent or enroll, but they actually don't have to provide that information. We're a little bit concerned about the slot reservation protocol. So we're going to fill some cancer types and stage really, really fast. Those cells will be closed down to accrual. We're actually, while we're concerned about that, the NCI has told us that it's a-okay to overfill some of these cells. And I forgot to change this slide. We had expected to activate in January of this past year, but it looks like we're activating August 1st for real. So thank you for your attention. I wanted to leave a few minutes for questions, and I will stop sharing. Thank you.
If anyone has questions, they can put them in chat, or you can just unmute yourself and speak up.
Well, if there's no questions, I would encourage anybody who might not want to speak up to just email me their question, and hopefully some of you will be solicited in helping to move the study forward at CU. Does anybody have any questions about actually opening and enrolling here at the University of Colorado? Okay, then we should get a brisk accrual.
Okay.
Thank you.
Thank you,
Dr. Wood.
Yeah.
It's Sherry. Can you stay on for just a minute?
Sure.
Okay. Oh, and Hatim does have a question.
Hold on, I gotta read it.
In the chat, is the study designed to compare different tests?
So that's actually a great question. Thank you. This study is designed to be a reference set. Patients are not getting results back, even the healthy controls. We don't know when these assays are going to be done. And it's mostly done for the NCI to be able to not validate, but to validate just the performance characteristics of the study, not to actually validate the assays. So then they have a reference set to do, and they will use that to define which tests go forward in the more definitive. But it could be used to compare different tests, but I don't know that that's really the point of this.
Okay.
Very welcome.
Any other questions?